I'm Bobby Beaulieu. I'm the program director here for both the Integrated Vascular Residency and our Vascular Fellowship. So we have an associate program director, which is Nicholas Osborne. Our section chief is Peter Henke. And then we have a program coordinator, is Allie Ammons. Essentially, we echo the institutionalist tripartite mission, which is excellence in the clinical space, excellence in research, and then the teaching mission. For our clinical space, we've really expanded that beyond just the adult focus, which I think is one of the unique aspects of our program. We certainly have the open and the endovascular clinical space that you would normally associate with a vascular surgery program. But we also have a pretty robust pediatric vascular surgery practice. For the teaching, we've really looked at that as a couple of different ways. Certainly the faculty are invested in teaching. They help to lead a lot of the lectures in a more formal manner, but also in the operating room. It's pretty much to a person a teaching philosophy that we treat the residents like their colleagues. And the goal is to make sure that you feel safe, like you can learn in the operating room, and you're pushed to just that limit of your comfort. And so you feel like you're advancing with each operation. The research, that's probably the area that we've expanded the most in the last few years. We've always had 2 years of academic development time built into our residency program. For a while, that used to be basic science research, and we still have a really robust basic science experience. But we've now expanded it into biomedical research. We have 2 of our residents that are doing actual research in a biomedical lab, doing flow modeling. And we've also allowed for more health services research with the CHOP program. And so we try to make sure that it's a tailored experience towards what you think you'll want to do research-wise in your career. The teamwork is what we recruit for, and it's also what we teach for. It's hard to teach somebody to be a vascular surgeon. I don't mean to say that the technical aspect of it isn't hard, but it's also really demanding, both mentally and emotionally, field. The patients that we treat are often really sick. Some of them are really young, and they have high acuity problems. So they have life-threatening illnesses that you're treating both medically and surgically, and it can take its toll on you. And so what we want our residents to graduate feeling like, man, I really know how to do vascular surgery. We also want them to graduate feeling like, man, I really know how I can be a person in this process and how I can dig into that emotional connection that we want them to make with the patients, bring their technical skills to bear to help these patients, but also know how to navigate some of those hardships that come along with treating really sick patients. We were one of the first integrated vascular surgery programs in the country. And so we've graduated more vascular surgery residents than most programs in the country. And that's even including the fact that we have 2 years of ADT time. So it's a 7-year program rather than the minimum requirement of 5 years. We've committed to having a vascular fellowship at the same time too. And I was a vascular fellow. And so I came in with the concern of, hey, I've done my general surgery residency, I'm the fellow, how am I going to interact with the integrated resident? Because you're both at a senior level, and it is seamless. I think having the long-standing tradition of having the integrated residency in place makes it a lot easier. So right now we have 7 faculty members. It's kind of a split. We have basic surgeon scientists, and so people who spend most of their time in the lab but still are clinically active. We have people who are split 50-50 that spend their time in the lab doing basic science and maintaining clinical practice. We have people who do venous, a lot of people who do arterial work, and so we've kind of got the role model set up. If you see an aspect that you think would be more relatable to you in your career, like what you wanted to do, you've got somebody that you can follow and be able to do that. We've got 7 residents and then 2 fellows per year. We have 3 APPs. They help to manage the inpatient side of things, and that includes helping to round and write notes and carry the pager, the responsibilities that kind of make it difficult to be a resident sometimes. We also have 3 outpatient APPs. We operate mostly at the cardiovascular center here, but we do have sites set up both at the cardiovascular center, at the Ann Arbor VA, which is only about 1.3 miles down the road, so it's nice and easy. And then 2 ambulatory surgery centers that we operate at in Port Brighton and East Ann Arbor, which are about 20 minutes away. And so we've kind of got a varied footprint, but not so much of a travel that you have to do. For the integrated residency, your first 3 years are going to be clinical, followed by 2 ADT years, and then you come back for your 2 chief years to make up a total of 7 years. We've been really intentional with the first 3 years. So the ACGME says that for integrated residencies, you have to have 18 months of general surgery services. And so we try to actually do most of those within the first 2 years, but certainly have accomplished all of those by the first 3 years. And that was a real intentional effort because we want to make sure that by the time you are the most honed at your operative skills and you're looking to get the technical skills you need to be a vascular surgeon, so in your chief years, you're only on vascular surgery services. The ADT time, the academic development time, is during your PGY 4 and 5 years, so after your first 3 clinical years. And it's usually about the end of your second clinical year that we sit down and start talking with you about what that experience is going to look like. When the residents come back from ADT, they come back to largely being on the inpatient service at the main campus, the CVC. They'll do 2 months also at the VA, where they'll be the service chief for the vascular surgery service out of the VA, which is a pretty robust service, active service as well. For our fellows, like I said, they come in, hit the ground running. They're clinically active the entire time. There is a requirement that both residents and fellows get something called the RVPI certification while they're here. And that's a certification that allows you to read vascular ultrasounds. It's a requirement from the American Board of Surgery now that to be certified in vascular surgery, you've got an RPVI certification. So we make sure that the residents and fellows get that while they're here. And then the fellows will spend most of their time at the cardiovascular center with a couple of months over at the VA. So nationally, there's a big trend towards endovascular being the primary makeup of the cases that people do. And so if you look at the national trend, it's about 70% of cases that residents are graduating with are endovascular and 30% are open. At Michigan, we flipped the script on that. So anywhere from 30 to 40% in the last year have been endovascular and 60 to 70% are open. And some of that has to do with the referral pattern that we get. Most of the open cases are complex aortic cases that we're doing to help either remove old endovascular grafts or treating problems that are not amenable to endovascular therapy. And so we really benefit. The average number of aortas a graduating chief needs is 8. And we currently do about 60 a year for our residents. And so they're really getting a robust experience in that. In vascular, we essentially have every Thursday, 7 to 10 a.m. are the didactic periods. So that's sort of the formal education part of it. That is a completely protected time for our residents. And so they get a chance to do either departmental DNC conference or our vascular specific DNC conference. We have lectureships that are also in place where we either have industry sponsors come in and give them lectures, or we have faculty give them lectures. We have trips to the Sim Center where people can learn at their level, all the way from how do you put in a central line or arterial line safely to how do you complete an endovascular aortic repair safely. And so we have kind of run the gamut of the Sim Center side of things. Every quarter, we have at least one of those days is set up as a wellness day where there's not actually anything planned during that time period, but they're still not expected to be in the OR or the pager. So 2 years of academic development time, and that is funded through a couple of different mechanisms. So we can make sure that they get either an F32 or a T32 grant to help make sure that their salary is supported during that time period. And we have a number of experiences. There's the basic science experience, where we have basic science labs that Dr. Gallagher and Dr. Obi have that can go anywhere from mouse to large animal studies. It can help prepare residents to be a surgeon scientist. But not everybody wants to be a surgeon scientist, and I'm totally keen to that. Our biggest area now is probably our biomedical engineering research. We have a faculty member who's a non-clinical faculty member, but within vascular surgery, who is a biomedical engineering PhD. So Alberto Figueroa has his own lab and gets his own funding mechanisms and does a lot with flow mechanics and how we model flow. And so we have residents that are on their ADT period that are working in his lab. Our entire goal in ADT is that you get a chance to see if this type of research, now that you've got the clinical foundation to know its applicability, if that type of research is something that you could see in your career. It's a small program, 1 resident per year for a total of 7 residents, and then 1 fellow per year for a total of 2 fellows. So there's 9 total trainees in a program of 7 faculty members. And so there are some natural mentorship opportunities that come from that. Some of it is who you click with. Everybody has their way of approaching vascular surgery, approaching life, and approaching the problems that arise from trying to make those two meld together. And I think the residents naturally click with different people. We have really accessible faculty members, and I think that's one of the biggest attributes of our section is that the entire group is just somebody that you would be willing to hang out with and kind of talk with. I certainly think that the residents come in at a very competitive salary negotiated by the House Officers Association, to which the residents belong. And that helps to make sure that you feel well compensated for the work that you're doing, especially when you compare things nationally. We've tried to, at a section level, make sure they feel appreciated too. We have non-educational outings where we'll go play, X golf, or we'll go do a couple of different, go to restaurants and things like that, and make sure it's just a chance to hang out and bond. There's also the wellness center, on the old hospital building where they can join for nothing and then go work out if they want to there. The money that's given to them monthly for their food stipend is generous and helps to cover all sorts of stuff for them. Most of our residents will eat their hospital or their meals at the hospital for the month at very little cost to themselves. I know that they'll get money through the HOA negotiation towards their retirement too. When you come through the Michigan Vascular program, we want you to feel like you're leaving as the best version of yourself. Now, the requirements are tough. A lot is asked of you, and you have to step up to the plate a lot. And so there are going to be times that you feel drained, and there are going to be times that you feel like there's a lot going on. But we want to make sure that when you graduate, you feel like you've been guided along a pathway that makes you the best version of yourself. And it's like that old John Lennon quote, life is what happens when you're busy making other plans. We want you to feel like your life is continuing to happen both inside and outside of the hospital. To do so, we want you to have good faculty, mentors, people that really model that, but also treat you like a person. And when we're talking about getting better as a program and as a residency, we try to dedicate efforts towards the things that are going to really improve how our residents perform in their life. And so having faculty that treat you like a person, having a group that operates on a team mentality. As faculty, if we get tired or we can't do something, we ask a partner to help us. We want you to feel like as a resident, you can do that too. And then if you go home, you're not going to have 8 sets of eyes looking at you and saying, oh my goodness, that person left. And so feeling safe, like you can grow into that space, is really the culture that we're trying to create.